Bonjour à toutes et à tous.
Good morning, everybody. The discussion about the freed hospital question mark is going to start. Our guests are Rodolphe Bourret, Marie-Sophie DESAULLE, Tobias GRAF, remotely, Laurence, JULLIEN-FLAGEUL, and Marie-Thérèse LECCIA, who is also on a remote base, and myself. Thank you very much. So in order to introduce the debate for today, I would like to quote an article from the magazine Gestion Hospitalière, dated 2016, which was summarizing today's discussion. Today, there is many discussions about freeing the hospital, freeing the growth, freeing the speech, freeing productive forces, and who can oppose to freedom, and who is freeing whom and from what. So it is a very trendy word, and the bet is that there will be a freed hospital that could be part of the discussion. What are we talking about? How can we free the hospital? It seems to be the topic of the day. Now, the second contextual element I would like to share with you is lying in a definition from the general concept of the freed move with a number of criteria, two criteria. The first one is to combine well-being and productivity, well-being at work and productivity. The second topic is the charismatic leader. The third one is how do we share values by taking actions, and the fourth one is how do we control things with shortened loops, and number five, the autonomy of each stakeholder at their own level, leading to the sixth one, which is the principle of subsidiarity and departitioning, and number seven, the reversed pyramid. How do people can work and decide for themselves? And the question is, how does that translate for hospitals? And I'm going to give the floor to Mr. Rodolphe Bourret, who is going to explain to us what he did in the Hospital Institute in Valenciennes. To give you a little bit of context, this is the first hospital institute in France with 5,000 agents and 2,000 beds. 10 years ago, a model was implemented. It was derived from the Magnet Hospital. The Magnet Hospital is a concept that dates back to the 80s, and it is derived from the corporation of nurses in the States, because they've seen, at that time, they saw that there was a shortage of nurses and carers, and they thought that the best way to appeal nurses was to work on the quality of cares. And what is the best way to work on that topic? Well, it is to work as close as possible to the field. And therefore, they've developed a management system, which is a collective and participatory one, with tripods of poles and governance. And those tripods, that's how they call them, are organized around one administrative person, a doctor, and a caregiver. And that's how the hospital in Valenciennes has implemented the model, putting in place a government system based on that joint management. And so we have focused on the poles, and we do have the responsibility taken by the management. So they do have some means, and also they have the possibility to take their decisions. So the hospital is not a structure-based hospital with a hierarchy, but we have reversed the governance within the hospital. And the governance is done by the field stakeholders. The experience in the hospital in Valenciennes is a very good one, because in fact, you know, the aim is to work on the quality of the care and then to put the organization in place to revolve around it. We've been in excess for the past 10 years. The hospital has been in excess and in surplus, but we have reduced the administrative structure as well. The administrative structure accounts for 5% of the overall budget of the hospital, while at the national level, the average is around 30%. Maybe just one word. How did you combine the quality of the care, the quality of treatments, which is something that is appealing to all, and on the other hand, efficiency, which is more on the business side? I believe that you've talked about an organization that would look like a business unit or type of organization. Could you please say a word about it? In fact, we have given the prerogatives of the head of the facility to the pole head, the head of the pole. So the head of the pole can make expenditures to recruit staff, for biomedical expenditures or hospital expenditures, even real estate expenditures. And by delegating those prerogatives to the heads of the poles, in fact, they can allocate all the hospital resources to the benefit of their work. And that's how we've increased quality. We've had many projects. We have a project culture, and therefore we don't look at projects under the angle of a medical economic model, but we look at the quality of the cares, and we put in place a business plan afterwards. I believe with the other speakers, we'll come back to those project management and how the project can be the driving force. Maybe the Dr. GRAF could tell us how it works in Germany. How do you combine the quality of the care, the treatment, and the economic efficiency?
First of all, thank you for the invitation, and I'm really pleased to talk with you from rainy northern Germany. I think we got the same situation as in France to find some magnet models. We call it a little different, like lighthouse hospitals. Finding some referral partners from top down to bottom up, and to find some patient and economically transfer on the state side. So our university hospitals are some kind of magnet hospitals as well. So we find them scattered around the map all over Germany, and they are land owned. So they just belong to the German states. And so we can work non-profit or non-deficit as well to find some better transfer policy from primary and secondary hospitals to these tertiary hospitals as well. So we find there some possibility to see this lighthouse system might be something that in Germany works as well. Even in the COVID crisis, we organized ourselves locally on regional base from the primary and secondary hospitals to these lighthouse hospitals as well. So this university hospital thing is about something like that. My fourth speaker just said some kind of magnet hospitals. University hospital took this function in Germany, I think a few years ago, and in the COVID crisis, we just seen that it works efficiently.
Et est-ce que vous pourriez aussi nous expliquer comment fonctionne un mode de
Could you please explain to us how the contract placing takes place between the different stakeholders, between the university hospitals, the first recourse hospitals, but also in the lenders, as you said, or at the federal level? What types of contracts are taking place?
So I think it's quite different. So we from France. So we had some cooperation contracts between the hospitals on local base, but we were asked from our lender base to say to work together, and so this is some kinds it's administrational, but the most of the time it's hospital to hospital contracts, and we got some clusters around the states, the German states, working together with referral hospitals from the primary and secondary hospitals with contracts to the university hospitals, and there are contracts to refer the patients back to them. So this is a quite efficient system.
Et est-ce qu'il y a entre les hôpitaux publics?
Is it only between public hospitals, or does it also work with private institutes, and how does it work?
So it works on a cooperation base, even with private hospitals, but it needs contracts. It's about the reimbursement system in Germany to say, okay, everybody wants to take part out of the reimbursement system. So as a non-profit hospital, for us it's not that important, but for the private hospitals it's even more. And so the contracts that we are doing with them are really on a reimbursement base.
Parfait. On reviendra sur ce point.
Very good. We might come back to this. Mrs. DESAULLE, do you have any comments on the contract placing? Okay, so I am with FEHAP, which is representing the private sector, but the non-profit sector. To come back to the Valenciennes experience, it is true that in our FEHAP institutes, we are working on a contract base. It is the contract that is binding the director and the board of directors, because the director is being recruited according to a number of objectives that he must reach. If he reaches the objectives, that's very good. But if he does not, then the contract can be terminated. And this is being broken down in the different hospitals with all the doctors and all the medical staff. When they come to perform a number of activities, research, and the management will allocate the means so they can reach those objectives, but it is on a contract base. If one of the parties does not comply with the contract, then the contract can be terminated, or we can reassess the objectives depending on the evolution of the activity. And that contract type of organization is also going to be found in the teams, whether we're talking about departments or poles, it doesn't really matter. But there will be discussions in short circuits between the management and the staff, or the medical staff, that is going to make it possible to take quick decisions, to react depending on the population, depending on the specialties, on the medical techniques. And what is working well, in my opinion, in our model, is the short-circuit type of organization and the contract type of organization, the fact that there is responsiveness and the fact that we adapt to the means, and also the assessment. We're not always very good as far as assessment is concerned in our country, but assessing the contract. And at one point, you know, we look at whether it went well or not, you know, and if it went well, we will continue, but if it didn't go well, we will stop. And the fact that we do have that flexibility is giving to the medical teams and to the caregivers an ability to react, and the ability. That's what the freedom is about, you know, to have that ability to react. But, you know, it goes hand in hand with liability, because you cannot have one without the other. So here there is a social dialogue which is working quite well in our hospitals, because, you know, it's in our interest to react. If we see some discrepancies in the fact that the team project is not the same as the hospital project, then we'll draw the conclusion. So for us, the contract is a major element, so we can manage the hospital. Marie-Thérèse, LECCIA, maybe the fact that we would have the CME manager and the director at the heart of the system. Would you like to say a word about that? Can you hear me? Yes. So good morning, everybody. For me, the tandem between the chairperson of the CME and the director should be aligned to the policy of the hospital and what are the objectives that we want to reach in the hospital. I agree with what Mr. Bourret said about magnet hospitals, because that's where we want to go to. I'm going to talk to you about my own experience, which is University Hospital Center. With smaller centers, there is a diversity which makes it interesting, but also complicated for the specialties and the objectives in terms of health for each specialty. The core of the activity of university hospitals, the core is the service or the department or the pole with tendons, or also 3 entities together, the medical caregiving team. I think that team needs to get to grips with or recover with the administrative staff. They must come back to quality of the treatment and the relevance of the treatment. Then in the public-private hospitals or in CHU, the second challenge is companionship. And that's why, beyond the question of the CHU, it is one of the objectives that we have today, which is how to train our young people at best, and that companionship should be done on the field and should be included in the objectives of the magnet hospital. For me, the top management, with DGCME, they have to be very clear about who should be the first stakeholders the ones that provide the quality of the care and the training of the young professionals, and then all the quality research and innovation that go with it. And how do we manage to, at the end of the day, get that subsidiarity? I believe that people are not liable anymore, and you said it. Now, a head of department today does not know where his responsibility is any longer. There has been a transfer of responsibilities and of the steering of the system, and this is very often a blocking stone in our institutes, notably in CHU, which are big hospitals, and problems are more complicated because of those missions. You said it in the Magnet Hospital, we're talking about training, while we have the feeling that training is becoming the poor relation. But how did you manage? What did you put in place in Grenoble in terms of training? I think you've mentioned companionship. I think you've tried to attract students and make sure it was working. What did you do? In fact, the good thing was that the university has created a training center for health professionals. So very early on, as early as the second year, we try to federate the work of all the different sectors, nurses, doctors, physiotherapists, etc., to try to work together, to train them to work together. We need to integrate those young professionals very early on to look at what their expectations are, and it goes hand in hand with the prevention of psychosocial risks. We've been through a very difficult crisis. The social atmosphere is still complicated. So I think it's a major challenge for us, that transitional period of time, the prevention of psychosocial risks. And so we're working in very small groups, and there is a contract, an integration contract for those young professionals, so they can share the missions and look at their responsibilities. And the chief doctor has a key role to play, and also a health executive, which could be a nurse, and it's a spirit of mind. In fact, companionship is a spirit of mind, and hopefully it will also work on loyalty and attractiveness. Okay, the Magnet Hospital, but also the loving hospital, because the hospital has to love patients, but also the staff. So, Mrs. Jullien-FLAGEUL, could you please tell us, maybe during the COVID crisis, how did you manage to take students on board right from the beginning, and also the staff? Well, right from the onset of the crisis, like all health facilities, we have prepared our plans for the continuation of the activity with 10% of absenteeism. The areas the most hit, the Great East and Paris, and we thought we had to think about outside our facilities and to go and look at students, so medical students, with the help of the CME, but also with the dean and the general manager. We went to see those medical students, and we explained to them what their mission was going to be, why we needed them. And they gave us a very strong answer, and they provided a great number of volunteers that we've been able to work with during the crisis. We've also worked with the directors of the Institutes for Training Medical Professions, nurses, caregivers, physiotherapists, and we have deployed with them a number of actions. We've taken a number of actions, and we've used the student skills early on, very early on, and we've included them in our plans for the continuation of the activity. So let me summarize very briefly. We've listened to the word quality, which is what is attracting to the magnet hospital. We've seen that in France we were still focusing on the public hospital, but in other countries, like Mr. Graf said, there had already been openings to the private sector in a broader way. We've also mentioned the topic of the contracts, which is also pending to the other side of responsibility to be able to take on board all stakeholders, including students, as we've seen. The second topic, behind that word of freed company or freed hospital, there is the notion of, we don't want to talk about reducing the fat anymore, but don't we have too many structures, too many standards, too many procedures? Aren't we bogged down in those topics? Marie-Sophie DESAULLE, okay, this is your favorite topic, I believe. It's time to talk about it. Well, the answer is yes. I think it's the same thing as the principle of subsidiarity, the same idea of that freed hospital. At one point, we need to be able to trust people. And the problem today in our country is that we don't trust. We don't have any confidence. And I'm talking about within the hospital facility, trusting the teams and giving them the ability to innovate and to make proposals. But that's also a problem that we'll find between health facilities and the pricing and control agencies, regional health agencies, which overall tend to apply a policy decided by the Ministry of Health, which is extremely rigid and which is more like trying to control afterwards rather than controlling beforehand. And I'd like to use an example which is the most revealing. Agnès Buzyn, for example, she wanted to make some experimentation in the framework of Article 51. And, she gave rise to a lot of hope because we thought we were going to be allowed to experiment and make proposals. And then we had a 37-page circular explaining to us how to do it. So the fact that it's so difficult to have that confidence, and I believe this is the cultural obstacle, the main cultural obstacle for us to move forward and to allow teams and facilities to be innovative, and even to territories. And I was talking about internal contracts, but I think the contracts between health facilities with the medical social sector, with the community medicine on a given territory, because we need to answer to a population health needs, and we need to get organized to answer to that need. And I think that's the right way of working, rather to having top-down dynamics or approaches that are neutralizing. And what happens is that everybody is waiting to see what the government is going to expect from them. What are the texts going to say? And so people tend to be on standby. And the COVID crisis has unblocked that a little bit, because the government has realized that they could not provide all the answers, and stakeholders on the territories had to organize themselves so they could provide the answer. But we need to keep that new system in place, that possibility of being able to react at the territory level, and the government has to remember that in case of a crisis they cannot do everything. And so in a more routine time, the government has to know that they cannot do everything. I think there was a topic about the medical CME, the Establishment Medical Commission in French. No, I was about to talk about the FEHAP, but in fact, my request is, please, let us get organized. Let us, and we're not, the government is not leaving us doing it. But I think it's also part of that confidence spirit of mine. There are different realities in different territories. There are different facilities. And therefore, we should leave it to the local echelon, the organization there, leave them to get organized.
So if there's a need to organize, restructure the dynamics of these in our private and sector, well, local basis, that's what we're saying, let us alone. I don't know whether it is linked to the public status of the university hospitals, but some of these status are seen as superstructure, not necessarily in a good way, in a positive way. Super as in superfluous. Okay, in any case, that can be understood as. First of all, I totally agree with what has been said, even for a university hospital. We need to simplify. And we need to decompartmentalize. And this, really, I agree with the two deans of medicine, medical and pharmacy studies. Now, I think this is the first point, and when I saying that, I'm talking about the territorial scale and local scale. So we need to take advantage of COVID as a fantastic accelerating factor to open up mindsets so that people can no longer have this wait-and-see approach, and the responsibility is that of a head of a unit or a head of medical center, because when we work with a regional agency, and they are, frameworks are very, very difficult to change, and if the dynamics as given by these joint authorities is not about opening up, then we've got a problem. So, following in the footsteps of what has been done in a university hospital, we need to implement the key transformation and address the key challenges. And involving medical units. And this is what we call the cluster of professionals in healthcare services, bringing together local authorities, patients, amongst other players. And we need to discuss all these key challenges And within our local medical council, we've invited representatives of the various healthcare professionals. We have a number of statuses pertaining to university hospitals, but beyond that, we have directors on core structures. It's always a complicated exercise to size to have a reasonable size, a size that allows to have a proper debate. And this is about diversifying and really covering this vast array of objectives. So then this council, I would understand that from university hospitals to university hospitals might take different form. One word we mentioned earlier, one of the fears is, with the free hospitals or liberated hospitals. And this is about staff cuts and cuts in support functions. I was reading or reviewing a study for an IF Europe dating back to April 2020. So at the core of the topic, hospitals employ 34% of their staff with no medical tasks. That means that 35% of hospital staff don't deliver medical services, and have support functions. So can you tell us a few words about what has happened with the magnet hospitals concept? Has that divided by two the support functions in terms of headcounts? Well, this has significantly optimized admin functions, as we have 50% of our expenses relate to support functions, and hospitals employ about let's say 70% of staff involved in care, 30% of medical doctors. Now, if this is about trust moving towards autonomy, empowerment, and delegation of powers, and really this motivates, this plays a very strong motivating factor. And so you've basically empowered the health centers director, the local health care managers, what we call the medical cluster business units, and your operatives tend to recruit operatives themselves as opposed to hiring support functions. Is that what that means? We oriented hospitals towards an efficient-driven culture, project culture. And we've wanted to, and we did create a hand surgery department within the Valenciennes and labor area and catchment area. We have major industrial businesses and with many labor incidents involving hand wounds. And so we worked with the top management with educating a hand-specialized surgery units. And this is something that we enshrined in the contractual framework. So the manager of that cluster developed a surgery unit specialized in hand surgery. And so a business plan was then developed, which we also used in these public hospitals, tools from private businesses without any shame whatsoever. We just get our inspiration from these private sector. For the time being, in any case. And we gave the resources to put in place this hand surgery unit, and he hired, this particular manager hired services of nursing staff, surgeons. Within 3 months, the hospital hand surgery unit was up and running, complete with all operating theaters. So in 2019, we were awarded the MEDEF and France Quality on operational efficiency, and we were awarded a prize for the from the regional observatory. So we can deliver value on public service values, and whilst using tools that are business-inspired or free business-inspired. So the point here is how can we give more autonomy and trust? How can we empower? So this is the very principle of the magnet hospitals. This is based on trust, and trust is based on something else, which is out of evaluation. And maybe, Dr. Graf-Petit, can you tell us your thoughts about support functions and their significance? We're talking 25% from on the basis of this study in Germany and 34% in France. So other countries still fare better or do, I don't want to say, but Denmark, 21% of their support functions. Dr. Graf, please.
Okay, so I think there's a difference between German and French healthcare system, but I think what has been told before is that federal administration from top down in times of crisis has not been performed that well. So we were asked to organize ourselves in regions. Yeah, and this regional organization that helped us through this crisis. So in 24 hours, all the regions in Germany just put up a referral system to these lighthouse hospitals all the time, and just we were able to get over this crisis. Then we were really more lucky than other countries in Europe, because we had no super spreading as in Grand Est or Paris or maybe northern Italy. So we had some minor outbreaks in Germany in here, and could react there on regional base. And so I think federal administration allowed us to do so. They don't get involved in our systems, and allowed us on local base to find the best solution for the patients. And I think that maybe a role model for the future, to say, okay, there's some norms and certificates for these clusters, to say, okay, how does a patient go through the hospitals or through the healthcare system, and we can find some local based maybe better solutions for the patients. But on the other hand, we got some really big tasks to see. We have some aging of our population. We got lots of people awaiting to be diseased in the next few years. We got some vintages with the biggest birth rates in Germany going to retirement in the 50s and 60s, so-called baby boomer generation. And so this is the bigger wave than all the COVID crisis can always be, because we've seen that there will be lots more patients, lots more solutions has to be made there. And so the healthcare system has some bigger tasks in the near future to work out. So we got the same problems in France. I think we got an aging population. We got some problems with our reimbursement system, and all this together that brings some bigger tasks to work out. So I think the same situation in Germany, maybe a bit other system. But in the end, I think it has to go to regional solutions for bigger problems than to wait for a centralistic solution from the federal government.
Et peut-être juste pour comprendre, vous, en tant que responsable de cette unité,
you as head of this intensive care unit, do you feel that you're spending 1 day a week, 2 days a week, filling in tables, dashboards? I'm hoping these are not Excel as dashboards, but do you have to do reporting all the time?
I think it's realistic. I think it's realistic to see it's about 20 to 25% of my daily work.
C'est ça.
And these indicators are the indicators based on, focused on quality of healthcare or on financial aspects. I'm just opposing them, just to have a clear understanding.
Okay, but it's exactly that point. It's standard of care and certificating, norming, and the other one is reimbursement. So I have to work for our money, for our hospital money to get it.
Exactement.
Exactly. Laurence, Jullien-FLAGEUL, maybe one point, as opposed to Arnold, you're very much embedded on belonging, identity, values. Few words on that, please. How can we choose this scale of the service? I think we need to empower healthcare units, managerial They can promote projects, and they can drive projects, I think. And the various managerial units need to support these projects. As institutions, we do have a strategy which we need to articulate, and we need to support healthcare managers. They are beautiful ideas. They are really at the heart of what needs to be done. Patients come to hospitals for skills, and we therefore need to refocus on the operational units. And I think this is linking up with our second last themes. So we see the clusters can be multi-medical centers. What about this service? What are the ramifications of it? A given scale, a given funding, and a given medical center. So indeed, I'm talking about the service, the unit, it's something that's way more open than it sounds. We're talking about the healthcare branch. And in terms of the structuring and the strategic decision, those local managers are really have an important role to play. I think the knowledge of players is really important. What we refer to in France as a GHT is a tool, has to be facilitated. Someone could coordinate, but as to the healthcare, in terms of the healthcare operations proper, in terms of the knowledge and decompartmentalization is really important, be it at the level of the care units. Things work better when people know each other. And that resonates well. It means that for the patients, when it comes to the scaling of healthcare services, and in terms of the care delivered to patients. I think there's a new acronym to offer for you, GHT. So shall I hand over to you now? Well, thank you. I understand the logic of hospital cluster development for public hospitals to organize their operations in a local logics. But these are public hospital clusters, and the logic of this does not allow to recover a healthcare branch that will include all of the players of other healthcare centers, private, profit or non-profit, for profit or for non-profit purposes. Now, as was clearly stated for Germany, aging is going to be playing a key role going forward. And will keep us very, very busy with new chronic diseases or growing number of chronic diseases and impacted patients. Now, I'm talking about those in medical social, those working with the elderly, and all this ecosystem. So I do believe that GHT is not does not provide all of the answers of the local care. It's about a territorial project that need to be co-constructed, co-built in beyond a top-down approach. It's got to be a cluster, a grouping of players that will develop on a basis and operate on a basis to provide a response to local needs and as per local needs, as per local patients' needs. So, voluntaries, yes, it's a key word. But the point here is, what is your take on the fact that there's over 800 establishments among the 135 groupings? Does that mean that there's we have some that find it difficult to bring together all of the medical fields of specializations as and patients need to be transferred elsewhere? I don't care, to be very, very frank with you. I do believe that we need to put an end to this myth of equality of treatment amongst territories, amongst local territories, because priorities of treatments are not the same, and if you are in the north of France, or in the south of France, or in the west of France, or in the east of France. So we have different players as well, different requirements, different needs. And in some of these local territories, we definitely need to take into account the reality of the needs out there and the reality of the players at stake. So this will to all the time and systematically to organize an equivalent organization evenly across the territory doesn't make sense. I would prefer for us to give our territorial players key challenges in terms of quality indicators, support, care, quality indicators, indicators focusing on diabetes, and then prevention, around prevention. As the population will have more and more people amongst the aging population, the population that is growing in numbers. So we have to go beyond structuring, because this will be too time-consuming. So maybe Dr. Graf, maybe one point to understand how that articulates. What is the network? How does that work? What type of within the lenders, how many equivalent of corporations of clustering or grouping, maybe not called GHT as is the case in France. So is that going to encompass all the regions or a subdivided regions? What is your take on this?
So it's quite interesting because every kind of lender prime minister found their own solution for that. So we don't have a general idea how to do this clustering. And I think we are in the land of Schleswig-Holstein, we just organized ourselves. There's some more centralistic system than, for example, in Bavaria, they had more control from the lender government. So, but I think the system is quite the same. It's about maybe a population size of maybe 1 or 2 million people, and this population size is there's a pyramid of quite a few hospitals with a lighthouse hospital or magnet hospital in Valenciennes, for example, in the middle to bring the patients from a rural area to maybe a bigger hospital, maximum hospital. And I think these are grown structures. We know where our clinical partners are. We know we are in a rural area, and here we know all these players by themselves. The most of them, of the heads from the departments coming from in their education from the university hospital. So we know each other personally, and this means the personal aspect is really important. The second thing is the administrational contract level is important. Yeah.
Oui, Et quand vous parlez des acteurs, est-ce que ce sont
Talking about players, are these only players involved in healthcare or elderly folks' homes, liberals, paramedics, physiotherapists, midwives, nurses? Is it a whole ecosystem you're describing?
All these stakeholders are in the cluster. So we just organize ourselves about local administrations with elderly homes, with the I think firefighters that are organizing the paramedic system in Germany. And so we had this cluster system for all together. So I think this is quite a few counties around a bigger hospital working together.
Et ça s'est fait sous un... Parce qu'en France, vous savez que c'est toujours compliqué.
As you know, in France, it's always complicated because people have to be voluntary, have to be willing. It's impossible to impose a voluntarist approach. I think, how did that happen? There was a very strong system of reimbursement system and insurance system. In a very slender system, there's a very strong system there. Maybe one word on that, if you want to touch on that before we move on.
I think incentives are really important. What is the incentive for every one stakeholder or player there? Is it a reimbursement incentive? Is it a patient incentive? Is it maybe a local agreement incentive? So most of the time it's about the money. And the German healthcare system is a multi-billion-dollar economical system, and everybody wants to take part on it, because even if you're non-profit, you have to bring your deficits down to zero. And so if the incentive in the end is the money, and if you bring the money to the people, then they will cooperate. And I think even it doesn't matter if you're local, public, or private hospitals there. If everybody takes his share out of this, everybody will cooperate, I think.
Merci. Alors peut-être un dernier mot de
Thank you. A final word, Marie-Sophie, just a final theme. How can all these good ideas can be scaled up? And how come this doesn't, you know, we don't leave it at the experimental stage, because we experiment and then we don't scale up. So what is your view on that? How can we share good practices? How can we make all these experiments more mainstream within a region, a university hospital, a GHT, and again more widely so, because here we're trying to do that with Dr. Graf on a European-wide basis. This is a challenging issue. We have 3 minutes and 30 seconds. I'd like to get closing remarks from every one of the contributors. We need for every establishment, when it is on the scale of every establishment, on the scale of every local authorities, needs to adapt to the specificities of the local environment in a wider sense of the term. Practical example, we're in a kind of mid-mountain area, so traumatology is going to be key. We're on the border with Italy, so aging, migration movements, and we need to adapt to really respond and address public health challenges, and being mindful of this local-driven aspect, and within restructuring of the life of care centers, take into account local specificities. I think this can be addressed through what we've been doing today, i.e. the fact of sitting around the table, and just as we said, in terms of local approaches, interpersonal relationships play a key role. I'm going to have to interrupt you here. Laurence, Julien-Flageuil, what is your recommendation for the sharing of good practices? You have 30 seconds. Trusting players, simplifying, leveraging and taking advantage of this health crisis period. Don't stick to experimenting. It's got to be part of our day-to-day life now. And this needs to be accepted as a way of working. on a day-to-day basis. So in a sort of normal kind of mode, so as to decompartmentalize. Sophie? Except, well, the FEHAP, my organization model, which is the best one, of course. No, in these roundtable discussions, I think exchange of practices, leveraging practices, regional basis and the level of federations, everybody can contribute, not necessarily mainstreaming. So capitalizing, leveraging doesn't, we must be mindful of specific needs of territories or local needs. There's a reasoned approach, i.e. under such and such conditions, we must move, we must opt for these kind of more general approach. So this is a kind of a love. What do we do with loving hospitals the old school way? So we need to have a global reasoning or a global reflection, but a local action, because this is part of has to be part of a local, regional strategy, national strategy, but the action has to be local driven, inspired on the basis of local context and local issues. So this Valenciennes experience in northern France has to be more mainstream in university hospitals, which is our really spearheading what we do. We need to apply this on a local basis. And the final words for Dr. Graf. Europe, you've welcomed 6 COVID patients in your hospitals, in your units. What can we do more? What more can we do? Tell us.
Okay. Just for the 6 patients from France that we treated here, I just wanted to tell you as a last word, we were really honored to host them here and to bring them back to France as well, healthy. And we never felt that European, and we never felt that France with the people in France as in these moments. And I really, it filled us with joy and with happiness. Thank you.
Merci pour eux et merci pour votre participation.
Thank you. And thank you for your contribution. Thank you for these patients. Next debate will start at 12 sharp. And this will be about working together. Thank you.